Intraosseous or IO access is important in an emergency situation after 2 failed cannulation attempts. It should be the first line access in a collapsed child. Contraindications include using it on the site of any bone fracture, use on a limb with proximal fractures, use on the site of previous attempts, overlying site infections, osteogenesis imperfecta, and osteoporosis. It is important to wash your hands again with soap and water before gathering your equipment. Next, the practitioner must gather their equipment, including IO needle, gauze, sterile drape, chlorhexidine, taper tape, 10 ml syringe, 10 ml saline flush, and a sterile field. Next, it's important to get the child into the correct position. Flex the child's leg at the knee and ensure the leg is stable. You may need an assistant to hold the leg. The appropriate position in a younger child less than 6 years old is the proximal tibial plateau, 1 to 2 centimeters below the tibial tubercle on the anterior medial surface. In an older child, the junction of the upper middle thirds of the tibia on the flat medial side. It is important to avoid the growth plates when inserting an IO needle. It's important to wash your hands again and put on sterile gloves before starting the procedure. The procedure will now be demonstrated on a chicken bone. The practitioner must clean the skin with chlorhexidine and drape the child. Hold the needle in the palm of the dominant hand and position it at a 90-degree angle to the long axis of the bone. Advance the needle through the bony cortex with a twisting and rotating motion, maintaining a steady pressure. A sudden loss of resistance indicates that the needle has penetrated the cortex and reached the medullary cavity. Remove the stylet and attach a 10 ml syringe. Attempt to aspirate bone marrow. Use only to check the blood sugar. Flush with 10 ml of normal saline. There should be no resistance. If resistance is encountered, reposition the needle slightly and attempt to flush again. If resistance still exists, remove the IO and attempt in a different site. Secure the IO needle with gauze and dressing tape. Check the site hourly for leg swelling and signs of extravasation. The most common complication is extravasation of fluid due to penetration of the bone or incomplete insertion. Other complications include compartment syndrome, secondary to fluid extravasation, fracture, infection, local hematoma, and pain. Aseptic technique is essential to reduce the risk of infection. The IO needle can remain in place for 72 hours.